Okay. Well, I want to thank everyone for coming today. I am absolutely delighted to introduce Dr. Andy De Los Reyes for today's InCHIP speaker series. Dr. De Los Reyes is a professor of psychology at the University of Maryland, College Park, and the director of the Comprehensive Assessment Intervention Program. His research seeks to improve our understanding of the discrepant results that commonly arise in mental health research. Andy has published over 150 peer-reviewed articles and books. He is the author of the Early Career Researchers Toolbox, which is a resource for early career researchers looking to build a research program and launch a career in academia. He recently authored Discrepant Results in Mental Health Research, which inspired a TED Talk on the topic of discrepancies in mental health data. Andy is the current editor of the Journal of Clinical Child and Adolescent Psychology and the co-chair for the revision to the standards for the educational and psychological testing. Personally, I have had the privilege of having Andy as my research mentor during my time at the University of Maryland and throughout my continued training. So I am very excited to welcome him for today's talk, Optimizing the Use of Discrepant Results when Using, Interpreting, and Integrating Assessment Data. So I will turn it over to Andy.
So much, Natalie, for that delightful introduction, and thanks to all of you for spending an hour of your time to talk about assessment. So what I would like to do today is go over a few things. First, I want to sort of lay some conceptual foundations for the issues that we'll be discussing here that generally revolve around what to do with data when their results point in different directions. We'll sort of talk a bit about what you might do methodologically when you have an idea about what data mean and you want to sort of subject that idea to a falsifiable test. We'll talk about some of the principles and practices that we might engage in. And we'll sort of use these theories, these ideas, these data to talk about some recommendations for what you might do with your data, particularly when they produce varying patterns of results that hang together and results that point in different directions. And I'll speak, as Natalie mentioned, I'll speak to these issues as they relate to a very specific thing that we all do, is assess domains that we think reflect mental health. And these issues in their own way might also apply or be relevant to a variety of assessments of other kinds of domains relevant to education. So we're going to be talking about a lot about discrepant results as they manifest in assessments, but they don't just manifest there. We see this stuff every day. When you're talking with people, significant others in your lives, and figuring out, well, what do we want to have for dinner? What do we want to watch at movie night? You know, to the degree that you're all sort of making judgments about what to eat and what to watch based on your own social histories, it's quite common for all of us to have differing opinions. Indian versus pizza, the residents versus the boys. None of those judgments about your taste in food or your film preferences or series preferences are inherently right or wrong. They're based on histories. We wouldn't call them biases. So they're discrepancies that matter in their own way. And those discrepancies happen in everyday life. They also happen in a host of different kinds of assessment scenarios germane to education. Using data to figure out the effectiveness of educational programming. Depending on the result, depending on the index you use, you might come to a different result. Making judgments, within families about how to raise children. Two, well-meaning caregivers can come to very different ideas about, principles and practices at home, what rules to set, what hobbies or interests might your kids be allowed to enjoy. This even manifests within structures. So within common law countries, we settle legal disputes using an adversarial system that quite literally pits two differing parties together who have disparate views but the same underlying evidence. So when we embrace these differences in judgments, opinions, attitudes for the unique value that they each might have, we might ramp up our ability to understand phenomena of interest and make accurate decisions. But a key thesis that underlies the work that our team does and the work that I'm describing you through today has a lot to do with the fact that oftentimes when data point in different directions, we encounter some tension because we might have some views about which pieces of data might be more or less valid or reliable or precise or what have you, even though we don't have a lot of strong evidence to justify that kind of claim. So if you could sort of boil down the work that our lab does to its most basic element, it's trying to address this question: what can we learn from these discrepant results that we often encounter in our work? I tend to seek addressing this question in places where discrepant results might be valuable, and so I rely a great deal on research that focuses on or tries to understand domains of mental health. And you can't see an anxiety disorder, you can't see depression, you can't see destructive behavior in the same way that a physicist can't see gravity. So we look and identify indirect signs that we've come to consensus likely indicate these entities, these domains we can't see. And so we might reference anxiety using an index of avoidance or fear of situations that we might find unfamiliar. We might index restricted behavior using frequencies or intensities of engaging in things like breaking into houses, buildings, or cars. We might index depression using a variety of different kinds of signals, like difficulty sleeping, or difficulty making decisions, or loss of interest or pleasure in things you usually enjoy. And we index these kinds of signals using all kinds of instruments: surveys, interviews, brain scans, saliva tests, all kinds of different forms of tasks that we think are indexing the same thing. And oftentimes, even though we designed them or intended them to index the same thing, they often tell us very different things about the exact same domains. Now, a lot of the work that I'll discuss here revolves around, yes, we use a lot of different instruments, but some of the instruments we use the most often revolve around trying to design instruments with item content that we think might be responded to in psychometrically sound ways from everyday people, not trained individuals, but people we administer checklists to that have items like, is your child shy? Does this child have difficulty paying attention? We have decades of research to indicate that everyday people can make these judgments. And oftentimes it's the case that we know a great deal about the mental health domains that we try to understand based on these judgments, which again, often point in different directions. Now, we have these scenarios later on, what I'll define as data conditions that are typified by different pieces of data pointing in different directions. But a key element, a key struggle that oftentimes our team encounters is this idea that the grand majority of the evidence we often collect in mental health, is unique information that any one source gives us uniquely. But a lot of what we do with our data is predicated on the idea that the only valid data that we obtain is from that sliver of evidence, that portion of variance where things hang together. And there are some important consequences if you make judgments, make decisions about these data, predicated on the idea that we only care about things when they converge, and not being incorrect or lacking evidence for being able to do so. What are the consequences of that? A great deal of the work that I'll be discussing today revolves around that question. When it comes to discrepant results, I think a lot about a concept that a lot of us use to justify gathering data, and that is situational specificity. This is a decades-old term. What does it mean? Well, situational specificity is grounded in this idea that a lot of what we do, how we behave, how we think, how we feel, is shaped in important ways by our environments. We often vary in how we behave depending on where we are. And so in a lot of our assessments and a lot of our measurements in mental health domains, we have to encounter them under the assumption that although somebody can be consistent in how they display signs of anxiety or depression or ADHD or what have you. They might be consistent across context. They might not be. And why might that be? Well, part of the reason why that might be is that contexts vary in their contingencies, in the elements of those contexts that are kind of like if-then scenarios. These scenarios that typify how we react to our environments and what are the consequences of those reactions. So something like feeling excluded by new people at school, like on your first day at school, makes you feel down and makes it difficult for you to build healthy social relationships. You know, to the degree that we are measuring mental health, we should be mindful of the fact that or comprehensive enough to take into account the reality that for a lot of mental health domains, how they might manifest in form or function or level can be dictated or relate in large part to variations and contingencies across relevant social contexts at home and school. And then if we're right in making that assumption about our domains and how they manifest in real life, the discrepancies that we see in our assessments might contain useful information. So one of the things that we try to make sense of in our work is this reality that for many of us, to the degree that we think it's justified to take a comprehensive approach to assessing or measuring mental health, we're following a theory that's telling us a few things, or informing us or compelling us to do a few things. If situational specificity characterizes how we assess mental health, then we should select data sources that vary in where they observe behavior. And if people like parents and teachers vary in where they observe behavior, and the people they're actually rating vary in where they observe, they display the behaviors that we're assessing, then these discrepancies can become markers for how behavior changes across social contexts and their underlying contingencies. Okay, so I've walked us through a series of aspects of mental health that I think many of us, to the degree that we're leveraging multiple data sources when we're making decisions, can more or less align or form consensus on. And so you might ask the question, well, if this is a theory we follow to assess behavior, then do we use this theory throughout? Like, for instance, do we use this theory once we gather all the information we've collected and use it to make informed decisions? A core thesis that underlies this presentation is, well, no, we do not. We don't actually incorporate the meaningful information that we might be gathering from data sources, even though it was all that we intended to do when we asked parents and teachers and kids in the first place to give us information about how kids think, feel, and behave. So let's think about integrating data. Why do we do this? Well, we do this oftentimes because we find ourselves often in a situation where we gather assessment data, they're pointing in different directions, but you still have to make one decision. You still have to make one judgment. Does this student you assessed meet criteria for a diagnosis or require an individualized education plan? Among those students who you administered an IEP, is it addressing their needs? Maybe you're conducting research and studying a school-based program. Are you gathering evidence that leads you to believe that the intervention is supported by evidence and ought to be used? These discrepancies, to the degree that they manifest by construction, forcing us to integrate data. But not all integrated strategies are created equal. And it turns out that a lot of the strategies that we often use don't actually capture a lot of the information that we think we're capturing when we're taking comprehensive approaches to measurement. And this is something that happens often. Over the course of several decades of study, the sort of average degree of correspondence between various people assessing children about mental health domains, parents, teachers, clinicians, children themselves, their peers, the correlations have stayed stable over the course of 5 or 6 decades. Correlations are stable across the globe. These aren't just studies we conduct in one part of the world. They manifest in every inhabited continent. And if Jacob Cohen was still alive today, and we asked him, like, hey, Dr. Jacob, what's the 99% confidence interval for crossing former correspondence? He would say, well, it ranges from moderate to moderate. It's a really stable effect. It's a stable effect when we assess behavior at one time point. It's a stable effect when we assess behavior across multiple time points. There's a meta-analysis published several years ago that took a look at 50 years of controlled trials and psychotherapy outcomes in outcomes of therapies delivered to youth, presumably well-established interventions. And one of the pieces that I focus a great deal on is, when this team assessed a host of moderators of therapy effects across conditions, the strongest moderating effect by far was the informant completing the measure. Other moderating effects didn't come close. And when you actually dig in to the actual informant effects you do see in controlled trials, you see profound differences in the magnitudes of effects for interventions for specific mental health conditions, right? And even for specific classes of interventions. The nature of your interpretation of the effects of outcomes for interventions that presumably you're using controlled trials evidence to understand if you should implement them at large scales, can lead to very different conclusions. In the case of depression, the ranges of effect sizes can lead you to conclude that either the intervention produces meaningful enough effects that I should perhaps use it to address youth needs for depression, to relying on the teacher. This might make you worse. This might be a harmful treatment. So what exactly about these interventions should we be attending to? Should we attend to the average effects that they produce, or alternatively, because they're qualified by moderating effects of informants, should we actually take a deeper dive into what these informants are actually seeing, and is there some value in seeing their unique impressions of the effects of these interventions? Okay, so when we think about the ubiquity of these discrepancies in mental health research and in mental health services, then how we integrate data becomes very important to consider. Now, those meta-analytic effects, mean effects, are estimates of converging information across studies. That's what we tend to do with meta-analyses. That's what we also do within individual studies. And the reason why is that we have a very specific idea about where valid data come from. We might use lots of different data sources to estimate mental health, but when we go to make sense of them, historically, we've relied on a very specific paradigm for drawing interpretations. I'm going to show you a series of figures that are adapted from Kahneman's great book from a few years ago, Noise of Flaw in Human Judgment. And the way that Kahneman breaks it down, judgments, you can break them down into 4 different kinds of patterns. Let's say you're trying to make a prediction. Is it going to rain tomorrow in Hartford or in New Haven or New York City or Boise or Alabama? Is it going to rain tomorrow? There's a right or wrong answer as to whether or not rain falls in Tuscaloosa tomorrow. In judgment, in Kahneman's mind, best case scenario is you got a bunch of weather forecasters trying to forecast the rain in Tuscaloosa. Best case scenario, they're all hitting the target. They're all correctly predicting the rain. Not all judgments are created equal. Some can be right on target. Some can miss the mark for a very specific reason. Kahneman calls that bias. Very specific pattern of findings. You can trace the source. There's also ways in which data can scatter. Maybe one person can get the rain forecast right, and a bunch of other folks got it wrong, but there's no particular reason for why they got it wrong. It's random. Kahneman calls that noise. And in most judgment decision-making scenarios, data vary for various kinds of reasons, not just one. But in this frame, The only set of correct judgments are the ones that hit that bullseye when there's one right answer. And everything else is either bias or noise, including all forms of discrepancy. Now, I just unpacked for you an assumption. Everything we do carries within an assumption. You administer a checklist to an 11-year-old child. You're making an assumption that checklist is psychometrically sound to yield useful information from 11-year-old people about their mental health, right? And analytic strategy is the same sort of underlying element to them. Before you click compute on an average of scores, before you say, well, your diagnosis is such and such, and you use some kind of integrated strategy to come to that diagnosis, you're accepting something as true about your data and its core characteristics. Assumptions are very important. And here are the assumptions of what I just laid out for you. You know, there's one correct judgment. It's going to rain tomorrow. The best data to arrive at a correct judgment are a few results that converge on the right answer, a bunch of really good weather people, or a stadium full of people that know nothing about the weather. Mathematically, you make that stadium large enough, you can approximate what the correct answer is from a series of really good weather people. You know, once you get to like 500, 600, 700, 800, 900, 1,000, you can get there. Every one of the strategies that we most often use follow those assumptions. Composite scores are the easiest case to navigate. They're just a simple average of scores. Whenever you do this, whenever you calculate the simple average of scores, know this. You're basically saying to yourself, saying to the program, I don't care that these say 10, 8, and 5. I'm just going to average them out, and what makes that index a 10 versus a 5 makes no difference for my ultimate judgment. It's garbage. Not using it anymore. Right? Now, that means you're tossing out all unique variants. You're doing the same kind of thing with and/or rules. So whenever you're making a diagnostic judgment there, you're relying on multiple people to make a decision. It's ADHD if both parent and teacher, endorse enough symptoms to justify a diagnosis. What you're basically saying also is, I don't care if one person says it but not the other. All I care about is the and. Right? So these combinational algorithms don't care about unique variants, but they treat them a little bit differently. So and rules don't care about single judgments, but or rules don't care about any one source of judgment. Just as long as somebody makes a judgment in favor of a diagnosis, if that's the decision, then that's what you do. You even see this in more sophisticated forms of integrating data. So here's a latent variable model that we'll talk about in a study down the line in this presentation. Not all latent variable models do this, but many do. They leverage indicators, sort of measured scores that produce some degree of variance, and latent variable models focus on decomposing those sources of variance into places where data sources hang together, common variance, and places where they don't, this unique variance. This particular model makes a very specific assumption of where the valid data lie. And the valid data lie only in that top circle. Nothing else is valid. And in fact, there are versions of this model that double down on this. Not just do I think that all that matters is that circle at the very top, but if you have a variable in your data set that you think accounts for some of the unique variance being reflected in bias, input it into the model so that we can account for it, because all discrepancies are bias. That's an assumption underlying use of this kind of model. Okay, so I love talking about this connection between assumptions and the actual places where you apply them to, the data you apply them to. And I love this quote. Nothing, not even real data, can contradict classical test theories. Mathematical psychologist from the 60s named Philip Levy. It's a beautiful quote because it reveals something core to all that we do. Structural equations modeling isn't wrong. A composite score isn't wrong. Saying an informant is better than everybody else isn't wrong. The assumption can't be wrong, but you can. if you apply an assumption to the places where it doesn't belong. And what I mean by that is that every assumption we make is always applied to data conditions. And so whenever we're making these judgments about ways of integrating data, we should be looking at them like we look at our measures. So before you draft a method section or put together a measurement battery to assess a student, presumably you're relying on evidence to figure out which of these instruments belong. And if that's the case, you're making an assumption that the evidence is sufficient enough to warrant use of the instrument. We should be doing the same thing with our integrated strategies. They might or might not have validity issues too. Only their validity issue is, does the assumption underlying use of the strategy match the data that I'm applying to it or fit the data that I'm applying to it? The great news is all this involves is repurposing good old-fashioned forms of validation testing. And the bad news is that if you don't do it, you set your data on fire. And you only keep about a sizable chunk, a discrete or small chunk of the data you ultimately collect. Okay, so I'm going to show you a series of studies that sort of articulate this general sort of validation approach. They come from scores of studies that have been conducted over the last 15 years. I'm going to show you 3 of them that sort of articulate a series of sort of if-then scenarios with situational specificity. So I'm going to show you each series of study, and it's predicated on the idea of if situational specificity characterizes your data, then the following is true. If this is what we use to measure mental health, and it accurately characterizes the mental health data we collect, then this thing is certainly true. There's more than one target. This is not like forecasting the weather, at least measuring mental health, right? Not like forecasting the weather. There is potentially a valid home target. There's a valid school target. There's a valid neighborhood target or peer target or whichever target you think accurately characterizes the ways in which mental health varies across contexts, across contingencies, across what have you. Now, what I find exciting about this idea, that there's more than one right answer when we're assessing mental health, is that if we're right, we've covered a whole lot more of the target area than if you ran on the assumption that there's only one right answer. Actually, one of the studies I'll talk about later on tests this exact idea. But we'll start off small by sort of identifying or understanding what it means to think there's more than one target when we're assessing a specific mental health domain, like disruptive behavior in young children. Now, we've known for a long time that children who engage in oppositional or disruptive behavior can display it in various kinds of places. So we know that children can vary uniquely in how they display these behaviors. Now, the question is how to test it. Back about 15 years ago, I had the privilege of being a member of Lori Wachslott's research team during my year of a clinical internship. And Lori is a developmental psychopathologist by training, and she devised an observational schedule called the Disruptive Behavior Diagnostic Observation Schedule. The name has the ring of the autism diagnostic observation schedule. The reason why is that the DB-DOS was inspired by work by Catherine Lord's extensive work on the ADOS. And what the DB-DOS does a little bit differently, though, is that several different kinds of tasks are administered within the context of interactions between children and significant others in their lives, namely sort of adult authority figures. And so the same kinds of tasks are administered within interactions between the child and their caregiver, and interactions between the child and an unfamiliar clinical examiner, which is supposed to be like a proxy for an adult caregiver with whom a child interacts in a non-home context. And because the tasks themselves are administered consistently across these interactions, these interactions, you can use themes and variations in children's behavior as a proxy for or independent assessment of how much a child's behavior varies across relevant social contexts. Now, it turns out you recruit a large enough sample of young children and administer them in this task, you can find a lot of variation in their behavior. These are the findings of a latent class analysis. It's like a factor analysis, but instead of looking at clumps of items and how they hang together, it's how clumps of people hang together, like in subgroups. And this is a dimensionally varying group of children. So some children who were recruited were clinically referred for disruptive behavior assessments or evaluations, and some children were recruited within screening assessments within outpatient pediatric medical centers, and some children were just sort of recruited from the community. So there's a lot of variation in here, and the grand majority of the children showed a low probability of displaying disruptive behavior across any of these contexts. Some children, the smallest portion of the sample, exhibited a higher probability of disruptive behavior across contexts. So that's the red team, at the very top, and the two groups in the middle, the green and the yellow group, the green and the blue group, were kids who showed elevated probabilities of exhibiting disruptive behavior within specific contexts, with an unfamiliar examiner but not the parent, or a parent but not the unfamiliar examiner. So this is a group of children for whom an independent assessment indicated they displayed disruptive behavior within across varying contexts. And the question is, do parent and teacher ratings, the ratings we often collect in clinical practice, follow along with these independent evaluations? And it turns out that they do. When you define disruptive behavior as it's an endorsement if the parent says yes, but the teacher says no, those are the kinds of kids that are significantly differentiated from that orange group at the bottom, but not the group that's the unfamiliar examiner only group. That finding flips if you change the definition of disruptive behavior. If you change the definition to, I'll only endorse it if the teacher says yes, but the parent says no, the parent only group no longer is differentiated by the orange group. Only the blue group is. Neither one of those two groups are differentiated by the orange group when you implement an and rule. I'll endorse disruptive behavior if both parent and teacher said yes, right? The only group that stays differentiated is that red group at the very top. Here's a piece of evidence to indicate that, at least in the sample, parent and teacher ratings of disruptive behavior were markers of contextual variations in behavior among children, right? So these discrepancies allow us to sort of unpack that contextual variation in behavior, but only if you assume that there's more than one right answer for how a given child behaves. It's the only way you get there, right? Now, when I look at these data now, 15 years after conducting the study, I ask myself a lot of questions. Is there any way for us to use these kinds of data in the context of making informed decisions about services? Can we use these data to personalize service delivery? Right? Now, that takes more than data. And that's one of the reasons why it takes so long oftentimes for laboratory-based studies to translate to clinical practice, to changes in clinical practice guidelines or recommendations, right? Research to practice gap. What's the average time? 20 years between basic research to applied research. So I got only about maybe 5 more years to go before I get in real big trouble for not following through on this stuff. So I got to act fast. And one of the things that's helping potentially turn these laboratory-based data into action is an emerging body of work called measurement-based care. Now, this is a term that excites a lot of us now, including myself. But it's important for us to know that people were studying this a few decades before it was cool. Michael Lambert's group developed an instrument several decades ago called the Outcome Questionnaire, originally developed to assess adults. Now, over the last couple decades, also developed to assess youth. There's a parent youth report, but not a teacher report. That's the problem with this instrument. But within the context of work with adult psychotherapy, this was an index that for a long time stood alone as an index, a sensitive, accurate index of week-to-week changes in functioning. And when you implement an index like this in a clinic, you see profound variations in how clients experience change, even if they're being administered very similar kinds of interventions. So Lambert developed this really neat instrument, passed a bar of psychometric rigor that few other instruments pass, but they went one step further and they asked themselves, what if we went beyond giving clinicians line graphs with these data plotted on them and actually translated data to things, to icons, to indicators that people can understand even if they know nothing about data science. So they use stoplights on a signal, and whoever on their team figured this out. I hope they're working for Nike right now because this is brilliant stuff. Look what they did. They took the stoplight signal and they randomly assigned clinicians in a clinic to two groups. One group received this like Cadillac outcome questionnaire data on these line graphs, beautiful data, well-established instrument. That's all they got. The other group got those same data and one extra tiny thing, a sticker on every client's caseload, every client, their caseloads folder that said one of these three indicators. Green, relative to what we typically see in this clinic, they're doing well. Keep doing what you're doing. That's all they got. All they got was the green. Yellow, they could be doing better. They could be progressing better. Red, danger. Danger, Will Rogers, danger. This person's at risk for deterioration. But all they got were the colors. The group that didn't receive that feedback, their clients experienced greater rates of deterioration and lower rates of improvement when contrasted with that group that got feedback. All they got was the sticker, nothing else, no other feedback, no nothing, just the sticker. And that reduces rates of client deterioration in meta-analyses, within 10 to 15 to 17%. Not a lot, but it's also not a lot of effort to put a sticker on a chart. Right. So, I look at these data now and I say to myself, that's work that's mainly done with adults, only based on self-report. So we have a superpower that a lot of our colleagues who do work with adults don't have, the ability to capture data across contexts. What if you had data about stoplights, but it wasn't just, I know what went red, I know where in the neighborhood it went red. We'd be able to get week-to-week indices, an understanding of how people function or change over the course of interventions. And what if a child from session 1 to session 5 suddenly starts getting that red indicator at school but not home, or home but not school? You presumably would administer a different kind of intervention. You'd work on different kinds of role play activities, different kinds of elements of care. The sessions themselves would look fundamentally different if you had context-sensitive information about how they were doing over the course of care. That's one way in which these situational specificity can help if we follow through on integrating data. If situational specificity is true, then this also must be true. There's no such thing as a best informant. You might have an idea like this. The best sources of data about ADHD are teachers. The best source of data about conduct problems are parents. The best sources of data for depression or anxiety are children. You can be right. And that's still the same thing as assuming that person is all-knowing if you're relying on them to make a decision and nobody else. So here's another way to look at these data, not in the context of characterizing functioning within context, but using data to make informed judgments over time. So I really enjoy going into assessment context where everyone tells me the discrepancies are junk, and then showing them not so fast. Assessing internalizing problems within the concept of acute care is a place where, interestingly enough, discrepancy happens often. These problems are often difficult to see, difficult to interpret, difficult to understand, and when present long enough, they might pose increased risk for things like being administered or being subjected to interventions that are predicated on the idea that you're not safe. You pose an immediate danger or threat to yourself or others. All right. This is a place where internalizing problems occur often. And we might say to ourselves, well, isn't this one place where everyone can agree that someone needs help? Isn't this the place where agreement should happen often? And it turns out that in acute care settings, we see the same kinds of disagreements in terms of level and function that we see everywhere else, which has led a lot of my colleagues to question the value of self-reports, the value of parent reports, the value of both reports. Maybe none of them are giving us useful information. Well, let's see about that. Well, when you look in these settings, you oftentimes will see the same kinds of varying patterns of unique information and converging data. And the question is, do they tell us anything important about care? It turns out they do. So even in an acute care setting, where people might be posing an immediate danger of threat to themselves or others, you see profound variations in ratings. Parent reports internalizing issues the adolescent doesn't report. They both agree on there being lots of issues to take into account or address in services, or the other direction. The adolescent reports behaviors the parent doesn't endorse. These gaps between ratings have clinical value. The group that's typified by the parent endorsing internalizing issues that the adolescent doesn't is at increased risk of being administered interventions of last resort, sedatives to reduce behaviors that they want to avoid, and being administered locked door seclusion, solitary confinement. These are the kinds of interventions that nobody wants to administer. Folks on the unit would rather focus on therapeutic elements to address the adolescent's needs. I look at these data now and I say to myself, is there a way for us to make good use of these data? Not just assume that one person is right and one person is wrong. Because the only way in which we can make informed judgments based on these data is to say to ourselves that it's important to look at each person's report relative to the other informant, right? If we had access to these kinds of patterns of behavior, what if they gave us a marker for, in the case of parent high, adolescent low, maybe that's the adolescent telling us they don't want to be here. At the end of the day, that's what I'm using these data for. I'm not looking for these data in this context to assess the prevalence of internalizing problems. I'm trying to use these surveys to make high stakes decisions about this person's life. What if these data are less an index of internalizing issues and more a marker of, I don't want to be here? Because if that's true, I'm contacting my buddy, Kimberly Becker, who has expertise on developing and testing evidence-based strategies for increasing engagement in therapeutic settings. So I have this data at baseline. I can make an informed judgment about the kinds of people on the unit that I have to attend to, and I have to improve their engagement, make them want to be here and get better. So all this culminates, at least for me, in thinking that if there is no one right answer to mental health, and it's important to look at these data relative to each other, not in isolation of each other, then maybe it makes sense for us to strategically identify data sources, not because they're going to tell us the same thing, right? But rather, they're going to tell me different things for good reason. So I got to treat my data sources like I'm trying to get to a restaurant, right? I got to capture unique variants, capture common variants. What do I mean by all of this? Well, the work I'm going to describe here comes from a book that we just put out in March of this year, and it's predicated on this idea that Helena Kramer, a statistician at Stanford, had many years ago, and the idea goes like this: in order for us to get from wherever we are to a destination, to the degree we're relying on the map application on our phone, the application isn't picking its favorite satellite to track you. It's gathering a series of satellites that are tracking your signal, tracking your location, but from fundamentally distinct points in space. Systematic variations in latitude and longitude, right? What those GPS signals are essentially doing is gathering expertise from distinct satellites. And their expertise is valuable insofar as each satellite is in a different point in space, right? That's how we get to one place to another. Perhaps, as Kramer argued, perhaps that should also be the same way in which we gather assessment data. We should be treating our data sources, our informants, like satellites. Right? So what do I mean by that? Well, the trick is to think about and recruit data sources within natural environments that we think are relevant for understanding mental health. A parent being a good signal up from home, teacher from school. These informants are gathering useful information from, about who we're trying to understand based on specific context? Can we leverage that variation in expertise to ramp up our ability to explain behavior and optimize prediction, make better decisions? This concept is generally referred to as triangulation, right? So the ability of be able to use systematic variations in estimates, predicated on the notion that information, that valid information can come from all places, right? So the whole idea here, like satellites, is that it's important to strategically select data sources insofar as the patterns of data look like this, that they agree a little, but disagree a lot for valid reasons. Right? I'm going to show you an example that's based on work that we do in social anxiety. We've implemented this technique in a variety of other settings. Like I mentioned before, I look for settings where discrepancies happen, and they might be happening for good reason. And anxiety is a great place where anxiety happens. Anxiety is a great place where discrepancies happen. In that, people often exhibit the signs and signals of anxiety in fundamentally distinct ways, depending on the context and its underlying contingencies, and in particular, variations across context and unfamiliar contingencies. Right? So, to the degree that these discrepancies might be reflecting how social anxiety changes across contexts and contingencies, can we use these discrepancies to ramp up prediction? They're also a really great place for us to test the degree to which integrated strategies, fit or don't fit the assumptions or fit the data conditions that typify assessments of mental health, social anxiety being one of them. Now, what I mean about sort of testing the fit, like I mentioned before, we can use validation testing strategies to test integrated strategies, like we do testing the reliability and validity of scores taken from instruments. In this way, it's kind of like our first few weeks of stats class when we were inspecting the distributions of scores in a sample that we're trying to understand, right? Right? Underlying assumption of regression, ANOVA, t-test, any analytic procedure in the general linear model, normally distributed data. So this is something we've done. We can do with our eyes closed now at this point. Lots of practice inspecting assumptions. All we're doing here is applying that same principle of inspecting assumptions. And in particular, do all the valid data lie in one place versus multiple places? Integrated strategies vary as to which the assumptions they hold. So, we are conducting these data inspection tests, with strategies that people often use: simple average of scores, the best predictor among a set of scores, relatively sophisticated latent variable models, and this model that I'll call a satellite model, that's actually predicated on a fairly rudimentary analytic procedure. And what it basically is grounded in is this idea that, if you think there's good reason for why these discrepancies contain useful data, then subject those ideas to a falsifiable test. Force factor analysis to tell you whether or not your idea about variation in these scores maps on to your expectations. So instead of latitude and longitude, you're talking about variations on valid variations in scores. In the case of assessing mental health, there are variations in where people see stuff, the context of observation, and how people see stuff, the perspectives from which they observe behavior. These are the whys of discrepancies. If you're right, and these discrepancies are manifesting for good reason and along the lines in which you predicted, you will see factor analytic patterns, component loadings that map on to those ideas. What I love about the satellite model, what I love about any model that I use, I tell my students my favorite models are the ones that fail, the ones that tell me when they fail, when they don't work. I've seen this model work, I've seen this model fail. So I love this model. It tells me when not to use it. So it's one of those places where you could potentially capture all the information you might find valuable, where things hang together, where they disagree for valid reasons. And it's a really simple sort of principal components analysis that I'll show you in a second. You're using PCA in these kind of contexts in part because you think a lot of the data is valuable, and your assumption is that people do systematically vary from each other in where they observe behavior, which by construction means that you're assuming the components, the correlation between the components is zero. We tested this model in relation to a factor model called a latent variable model called a trifactor model that's grounded in a very different kind of set of assumptions, namely that all of these discrepancies aren't useful at all, so get rid of them. So you get direct estimates of unique common variance, but the assumptions are quite different, all focused on the common factor at the very top. These studies, we're gathering information from the people we typically rely on, parents and adolescents, and also an information source that we actually create in the laboratory. We simulate scenarios in which adolescents interact with people who they're led to believe are their own age, unfamiliar same age peers. In reality, they're very young looking undergrads. Like Tom Holland, pretending to be a sophomore in high school, Spider-Man 1. He could get into a bar in Spider-Man 1. He's 15 in the movie, but he's 21 first time. Andrew Garfield was 28 when he played Spider-Man, sophomore in high school. So each of these raters are completing social anxiety surveys that are parallel, contain the same items, right? And we integrate these data using this model. Like I mentioned before, the adolescents, in order to get our validity criteria, the ways in which we try to make sense of these data, they're being observed by independent raters within a series of tasks that are designed to elicit signals of social anxiety within unfamiliar scenarios. We collect these three raters. We train an independent rater who's masked to all their other data to serve as a validity criterion, right? That allows us to test these integrated strategies using modalities that allows to rule out shared method biases in order to come to conditions. So here's a neat thing with these data. These are three different informants completing the same instrument, and their data correlate in low to moderate ranges with the correlation between the pairs and the peers and the parents. The correlation data low is 1. They get pretty low, but when you look at their individual relations to observe behavior, they're all giving us unique variance. They're all checking the boxes on data with unique criteria-related validity, right? These are our data conditions, uniquely valuable data sources. What do these strategies look like? Well, here's the PCA of the satellite model. Every satellite model has these three components. A fair amount of data that hang together. Component loadings that all load in the same direction. Component loadings that indicate unique variance. So variance specific to context. Still a fair amount of data. Data that show you different kinds of loadings depending on where you see stuff. Perspective. Also a fair amount of variance, showing you differences in how people see stuff. So here in this set of component loadings, I got evidence to indicate that these data appear to vary in the ways that I expect. And now it comes time to actually look to see if these strategies are different from each other in their predictive value. So this involves subjecting that first score, that trait score, as an index in competition for unique variance of predicting observed behavior relative to the other strategies. Each and every one of these times, a trait score is outperforming the best informant, the composite score, and even a sophisticated latent variable model. So in each of these tests, we see that each and every time this assumption that it's important to look at valid data in places where they converge, but also where they diverge for a good reason. There's value in using this integrated strategy over and above the other strategies that claim that all the valid data hang in one place. 2 valid sources of variance are better than 1. All right. So take-home messages. I would like us to have consensus on the following thing. If there was enough good evidence to indicate that data source or that instrument belongs in your battery, and they disagree with each other, please stop and ask yourself, if it was good enough to include in the battery, might it be good enough to interpret now? Are these data sources satellites? Because if so, then we shouldn't automatically assume that what they're producing as a byproduct of systematic error or random error. But we shouldn't just say that all discrepancies are useful. We should falsify them. We should force ourselves to conduct tests that reveal whether or not these discrepancies contain valuable data. And then when they do give us valuable data, we can't stop at just looking at data. We can't stop at sharing line graphs with each other and students and teachers and administrators. We should be thinking like marketing executives. This is product placement. We got to think about ways of translating these data into feedback paradigms that anyone can understand, not just those of us who nerd out on data. Thank you very much.
Do you want to open the floor for questions in the last couple of minutes, if anyone has any?
I have a super quick question about what you do in the case of like maybe communicating this to parents or students or teachers. Is there a way to kind of like communicate that gracefully, or is it kind of just, luck of the draw?
Great question. I think it's useful for us to talk transparently about how normal this is. That it could be the case that people can all be on the same page about these really important things, like whether or not someone needs services for ADHD or anxiety or that this depression makes it hard for the people to complete assignments. And there's a reason for why we're collecting data from lots of people. If there was only one right answer, we'd only have to ask one person. But this isn't an episode of House, These are scenarios that can change in fundamentally distinct ways.
That makes a lot of sense. Thank you so much.
Maybe leave out the House part, but talk about how normal it is. One thing that I hope folks do more with this, I'd love to see more qualitative work in this space. I think we need to really think carefully with our colleagues in a variety of different service delivery settings, research settings, clinical settings, a variety of different settings, and sort of ask the question: what's going through your mind when you run into these data? This doesn't happen all the time. Sometimes we get assessments and the data come back and everybody's on the same page. But when they aren't, what's going through our minds? What are we doing? What are we following up on? Are we just accepting it as true? Do we actually have beliefs about who might be the best data source? There's some survey data indicate that we might have those beliefs, but the surveys are really old. And they might not be reflective of assessment conditions in the current day. I think some more qualitative work would be useful, not in terms of decision making, but also I think in terms of trying to understand how best to represent these data in ways that people can understand. Those feedback paradigms, I think are things that we should be thinking carefully about.
Okay. Well, thank you so much. This has been wonderful, and such a useful thing to talk about. It's something that I think impacts all of our fields a lot, and it's something that we just don't really have the opportunity to think about. And so it's really neat to really tackle these issues in a way that is such a different and exciting perspective. Yes, thank you, Eliza. Thank you also to everybody who came. I know it's a Friday afternoon, but this is just the coolest thing ever. So I really appreciate it. And I think that's our time. So thank you all and have a wonderful rest of your day.
Thank you so much.
Thank you. Have a good weekend.
Yeah, everybody have a great weekend. That was a great send-off.
Thank you.
Excellent.
Thank you.